WHO, about 662,000 children under 5 years old die in a year because of diarrhea. This is a very important topic, and as we will see over the next few slides, the relationship between diarrhea and nutrition status is paramount to the health of the child. The learning objective for this lecture encompasses 3 areas. The first, etiology, pathogenicity, risk factors, and nutritional implication of diarrhea. The second is the nutritional management of diarrhea. And the last one are complementary strategies that you can use during diarrhea. Obviously, during this section, we're going to understand the etiology of childhood diarrhea and health implications. We will ask you to understand the management of diarrhea, especially per WHO guidelines. And we will, at the same time, put some emphasis on breastfeeding and complementary feeding, as well as supplementary supplements that may be of benefit during diarrhea. We will discuss complementary feeding strategies and harmful practice because many beliefs are around us. So let's start with the first section where we will discuss etiology, pathogenicity, and risk factors. A few facts about nutrition status and diarrhea. Diarrhea is the second of the top 3 causes of mortality in children who are less than 5 years old. In this slide, you can see that mortality is exceptionally high in patients with pneumonia, but also in diarrhea and malaria. Almost 50% of deaths in children less than 5 years of age is attributable to undernutrition. Before we continue our lecture, what I would like to go over is a few definitions. The WHO defines diarrhea based on 3 or more loose liquidy stool a day, and they further divide diarrhea into acute watery diarrhea, dysentery, and persistent diarrhea. As you know, acute watery diarrhea is basically a lot of fluid loss and electrolytes very rapidly that result in dehydration. And there are multiple pathogens that are responsible for this. One of the most notorious is rotavirus. Bloody diarrhea is basically associated with rectal bleeding, and Shigella is one of its examples. Persistent diarrhea is defined as diarrhea for more than 14 days, and it can be accompanied or not with blood. And very often, children who are in this group will have problems with immunity and nutrition. This module, however, will not cover the management of children with bloody diarrhea and diarrhea associated with severe malnutrition, called also SAM. The next slide is mentioning some of the etiology and the burden of diarrhea through a very interesting study that's called GEMS. And basically, this was a 3-year study that was prospective with stratification by age, and it was a matched case-control study. It was performed in South Asia and in sub-Saharan countries. And basically, the goal was to identify what were the major pathogens that could be linked to diarrhea in children in different age groups up to 5 years of age. And what this study shows you is that there are 4 common pathogens that are observed outside of the hospital setting. Those are rotavirus, cryptosporidium, Shigella, and also a toxin-associated E. coli. As you can see in this slide, the incidence of moderate to severe diarrhea is around 30 per 100 child year. And infants in infancy, this is really the period of time where diarrhea is more often affecting children. The big problem with it is that there is a high mortality rate that's associated with it and can reach up to 56% of children who are in their infancy. And this was found in this particular study, the GEM study. In toddlers, half of the deaths are observed. In terms of long-term, what happens is that there are specific effects, and mostly in terms of nutrition in the area of growth, in height, and there are effects on mortality and survival. And for example, children with a single episode of moderate to severe diarrhea have a likelihood of more than 8 times to have a death compared to control children. So very high rate of mortality. One of the items that can be offered in addition to the management of diarrhea is its prevention, and we will talk in length about rotavirus vaccine and other methods to prevent and treat diarrhea during this lecture. In this next slide, what I would like to do is to propose a model that goes to the problem of diarrhea and its impact and its relationship with nutrition. And what's very interesting is that an infection in early childhood affects nutrition, and so we have a double burden here that exists between diarrhea and nutrition. But in addition, because of the effect that's persistent on height, and also put in an environment that's not favorable, where there is a lot of foods that are high in energy that are consumed, and lack of physical activity, the combination of the two will yield problems with obesity down the line. So now we find a triple burden of early childhood infection and stunting linked to obesity and its metabolic consequences. Let's touch a little bit on the pathogenesis of diarrhea. As you know, there are 3 major mechanisms that are resulting from diarrhea. One is inflammatory diarrhea, osmotic diarrhea, and secretory diarrhea. Inflammatory diarrhea, an example, is is due to infectious pathogen or neoplastic disease. Another, in terms of osmotic diarrhea, is the use of laxative that are going to be a stimulating agent that will trigger fluid losses through the gut. The third one, secretory diarrhea, might be, for example, alcoholism or bile acid malabsorptions that will have an active secretion, that will cause an active secretion of fluids through the gut. Let's move now to risk factors that may accompany, that may yield to diarrhea. There are multiple. First, they may be linked to the mother, and one example here in this slide would be poor hand washing practices. Another may be related to children, and they may be already immunodeficient, or they may be of low age. All those factors will predispose to diarrhea. Healthcare and immunization is another risk factor. As we just touched on briefly, the lack of rotavirus immunization is obviously a risk factor when you get in contact with rotavirus. Environmental factors are important. For example, areas in the world where there is no latrines and therefore a lot of contamination and orophageal problems. Or seasonality. Certain pathogens thrive in the warm period of the year, such as Shigella, or can occur in cold periods of the year, such as rotavirus. Now we'll move to the next section of this lecture, which is discussing the nutritional implications of diarrhea. As you know, there is a vicious circle between malnutrition and diarrhea. Infection will affect the gut barrier and impair the immune function at the level of the gut and result in malnutrition, and vice versa. So chronic diarrhea impairs nutrition, and malnutrition in kids will have an impact on future diarrhea occurrence and also on the longevity of the current episode. So let's talk about reduced dietary intake. We know that during diarrhea, a child will tend to be anorexic, and there are multiple causes for this. They will not want to eat because they don't feel good, they have fever, they are dehydrated, they may be nauseated and have vomiting because of the underlying condition. And other issues might be that there is malabsorption, so they have diarrhea, they don't feel good about eating because suddenly they're going to have cramps and have malabsorption. There are also other metabolic consequences of diarrhea, which are an increase in catabolism of protein, an increase in requirement. And so just the effect of diet is not just due to a decreased intake, but also to an increased usage. Another point that's very often forgotten is that there are a lot of human beliefs around the approach that one has to have to diarrhea. Some population believe that food should be withheld. Other population believe that the quality, the nutrient density of the foods have to be decreased to avoid adverse effects. And this can come from the medical office or be just identified in the neighborhood. So a lot of issues around knowledge and practices of management of diarrhea and nutrition during diarrhea. As discussed earlier, there are multiple changes that occur in the intestine due to diarrhea. The integrity of the cell is modified. There are problems of balance of fluid and electrolytes. And there are problems of inflammation secondary to the damage to the barrier from the gut. The effect of withholding food during diarrhea may worsen malabsorption when food is reintroduced. The catabolism that's happening in terms of losses worsen the negative nitrogen balance. And there may be some metabolic inefficiencies with increased rate of tissue synthesis in children who are recovering from diarrhea. And in those instances, sometimes children need some zinc to favor the reoccurrence of their tissue synthesis. During diarrhea, there is an increased nutrient demand, and that demand is quite elevated. There are studies that are suggesting that at least 25 more intake in calorie is needed, and that up to twice the amount of protein is needed to help maintain the nutrition status in children with diarrhea. Now we're going to move to the third section, which is nutritional management of childhood diarrhea. We are going to use a case scenario in this particular section to illustrate the management of diarrhea and use a guideline, more specifically that of WHO. As you will be seeing, we are not discussing every guidelines for every country in detail. We have chosen to provide some, during the discussion, several guidelines that are international, and we are well aware that every country has their own guideline in certain aspects of care. We will also touch on breastfeeding in this specific section and zinc supplementation. So we are going to discuss a case scenario here of a child who is 5 months old. The name is Amina. This child had 4 to 5 stool per day in the past 4 days. There were episodes of vomiting, but that was only on day 2. And this child was subfebrile, didn't want to breastfeed, and was found to be lethargic in the last 48 hours. When you see the child, it seems to be having sunken eyes. His skin doesn't release well after you pinch it. His tongue appears dry. He is indeed subfebrile. It doesn't look like he's steering very well. And you find that he has lost about 700 grams compared to his usual weight. So here you have quite a few worrisome signs. And now what we need to do is to see in what type of dehydration category this child is, and then we will define what is the treatment approach. The WHO is telling us that there are 4 important areas in the prevention and the treatment of dehydration and diarrhea. The first one is you want to prevent dehydration. The second one is if you have dehydration, you want to treat it. The third one is that you want to prevent malnutrition, but if malnutrition appears, you will need to address that too. And the goal is to reduce duration and severity and occurrence of future episodes. So multiple steps in the management of diarrhea. The essential elements are basically hydration, zinc supplementation, and counseling regarding feeding and prevention of malnutrition. The WHO is suggesting to first ask questions. So you want to know about the episodes of diarrhea. You want to know how long it has lasted. You also want to look for signs of dehydration, and the case scenario is showing you many of those. And if you look at the little tool that's included in this slide, what you will see is that you can assess by looking at the child, by feeling the child, and then you can decide if the patient has or not dehydration and how severe it is. So the big items on this list are basically if the kid has a change in alertness, such as that they're too restless or they're comatose, their eyes, because that will tell you if there is really dehydration, are they sunken or not, the level of thirstiness, and if, depending on the number of signs that you show, more than 2, then you will be able to say that you need to have a treatment plan B, for which we're going to go in the next few slides. And a treatment C, severe dehydration, is noted if there are more than 2 of those signs provided in the slide. So in terms of assessment of fluid deficit, you can assess it based on the level of dehydration, based on body weight loss of less than 5%, 5 to 10%, or more than 10%. And you will stagger the cc's per kilo based on that cutoff point. Now, in terms of amount of fluids that you will want to give to a patient who has diarrhea to prevent dehydration, what you can do is to administer fluids as often as possible until the diarrhea is gone. And you can do that with oral rehydration salts, ORS. Some people call it ORS, others say ORT because they talk about treatment. You can use salted drinks and you can use unsalted drinks. But you definitely need to avoid drinks like sodas, fruit juice because they're more osmotic, and coffees, or herbal remedies or teas that may be the treatment of choice locally, but are not based on evidence. So ORS initially had been built as a liquid that was isoosmolar, so meaning around 300 milliosmol per liter, which correspond to the osmolality of the blood. Unfortunately, there have been a few adverse events using that, especially in countries where there was no cholera, because it was tested initially in cholera population. And therefore, the osmolarity since then has been decreased. And in the next slide, you will see an example of the content of ORS, which I'm sure all of you are familiar with content of sodium at 75 millimole per liter instead of the usual 90 millimole per liter that was used in patients with cholera. In the EU and US, we definitely always use the 60 millimole per liter because we don't have those types of dehydration like cholera. There are barriers to the use of oral rehydration therapy, and those may be related to the patient or to the physician. I will go through just a couple of examples. Cultural practices might be one. The cost of ORS might be another. For physicians, they may not be trained properly, or they may be in a for-profit setting where it has been observed in studies that there's more prescriptions of antibiotics and more expensive medication instead of using ORS. Let's change our discussion and start talking about treatment plan. As you may recall in former slides, we had proposed three types of approach: a treatment plan A for mild dehydration, a treatment B for moderate dehydration, and a treatment C for severe dehydration. So the plan A is basically taking place at home, and what is going to happen is that you're going to provide ORS to the family. You will tell them to avoid sugary beverages and carbonated beverages, and you will really stress the importance of providing fluids every time the patient has a diarrhea on top of the fluids they're already taking usually. The next thing is that you're going to provide zinc supplements, and you will also talk about the diet. In terms of diet, you will ask that they eat the usual way, but in smaller amounts. You will not withhold the feeds. You will stress that those children who are breastfed should be continue on breastfeeding, and encourage the use of a cup, especially if they are not breastfed. The following rule is basically a referral rule, and this is when the children diarrhea and symptoms are worsening. The mother should visit a health worker if the child vomits repeatedly and passes many watery or bloody stools, is excessively thirsty, does not eat or drink adequately, has fever, or does not return to normal within 5 days. So all those are red flags, and you want to send this patient for further evaluation at that time. The treatment B is basically a oral rehydration therapy that is going to happen in a healthcare facility, but it's not really an hospitalization. So what's going to happen is that you're going to provide ORS to the patients during the first 4 hours, and you are going to reassess the state of the child. In this slide, you can see that there are recommendations for volume of fluids that you are going to give by weight and by age. You know also that you can use a spoon or a cup to provide the ORS. One of the issues is if the child has a vomiting problem, you're going to wait a few minutes, let the child rest, and then reintroduce a small amount of ORS, and it can be a teaspoon or 2 teaspoons, and see if he's holding it, and then continue your approach of treating with ORS. It is important to use clean cups. Hygiene is very important in hydration. And during your assessment period, after your 4 hours, you can decide if the patient is the same, is improved, or has worsened. And if the patient has worsened, what's going to happen is that you will need to use intravenous therapy. That's plan C. So your approach will be to use a lactate rangier or normal saline. You're going to provide a rapid IV hydration. You can also provide ORS at a rate of 5 cc per kilo per hour once the child is able to drink. The children have to be reassessed every 4 to 6 hours, and small children earlier. So in our case scenario, the child received ringer lactate, and he was exclusively breastfed throughout the therapy. Now, what happens if you have severe dehydration and you need to decide to provide IV therapy and you need to reach a hospital? The first thing you need to do is to figure out, does this kid still drink? If the kid drinks, is able to drink, then you're going to still administer ORS and reassess them before you have to decide to put a nasogastric tube and provide ORS via that mean. If the child doesn't tolerate the NG feeds, then you will have to send them very quickly to have IV therapy in a hospital. And in the meantime, obviously, try to give ORS so that things don't worsen. Now let's go to the next slide and talk a little bit about zinc therapy in diarrhea. Why do we give zinc? It has been shown in the literature that zinc will decrease the duration of diarrhea and its severity. We know that in the future, the children who have been repleted with their zinc will be less likely to have another episode of diarrhea. And it doesn't matter the type of zinc salt that you provide. The mode of action is basically stimulating growth of the cells and differentiation. You boost your immunity, and you help transport fluids and electrolytes in the gut. WHO has some criteria for supplementation, and Aspagan does too. However, in countries such as the EU and North America, we rarely use zinc as a therapy because it's extremely rare when we have zinc deficiency among our children. A next tip during diarrhea is breastfeeding, and the WHO clearly states that any child on breast milk or breastfeeding should be continued on that therapy. For children who are less than 6 months, they can be given reduced osmolarity ORS and strength milk or formula if they are not breastfed. And for older children, they need to drink, in addition, a lot of water. So we know that breastfeeding is protective. There are studies that have been done, and meta-analysis showed actually that the risk of diarrhea was decreased with the intensity of breastfeeding, with that there was a protective effect regardless of age, that there was a decrease in hospitalization and a decrease in mortality. And you can see that with the relative risks that are under 1 in this slide. Early refeeding is another thing that's very important during diarrhea. Why? Because it's going to improve regeneration of your cells, and it's going to improve the buildup of enzymes such as disaccharides. So there was a systematic meta-analysis that was done and showed that actually there was no evidence that early refeeding was having adverse effects on diarrhea. Espagen recommends early feeding during diarrhea, especially after rehydration therapy has been done, and recommends that diet be not withheld for more than 4 to 6 hours, and breastfeeding should be continued in children who are breastfed. Appropriate feeding during diarrhea is important to prevent malnutrition, to promote weight gain, and we know that diet restriction has an opposite effects. Where you lose weight, you have worsened diarrhea, and you may have problems with height. So let's revisit again frequency of feeding during diarrhea. Remember, no withholding feeds. You want to give small amounts at a time, but frequently. If the child is breastfeeding, you want to breastfeed. You want to use cups rather than bottles. If the child is on formula or drinking milk. You also want to give high energy foods for at least 2 weeks after the episode, and you will be giving extra meals to children who have already a nutritional problem. Feeding are going to be dependent on the age, on the diarrhea, and on all types of environmental circumstances. Let's start with the choice of recommended food in the first column on your slide. It should be first culturally acceptable, energy dense, and you want to make sure that for the small kids it's mashed so that they're able to swallow it. For children who are more than 6 months, it is clear that you need to have a good source of protein. Therefore, there is a lot of emphasis on meat and fish or egg. Also, you want to use fruits and vegetables that have potassium in them in higher amounts because this is an electrolyte that is lost during diarrhea. And there are other foods that you may use for complement. During diarrhea, you can also shift the types of foods, such as in dairy products. Instead of using milk, you can use yogurt, the better tolerated. It's important to limit milk that's not breast milk to 50 cc's per kilo per day, and to give at least 6 times a day small meals for children who have persistent diarrhea. So as we said a little bit earlier, the effect of high calorie intake in hospitalized children will decrease the duration of the diarrhea and the severity of the diarrhea. And once the child is able to tolerate feeds, what you want to do is to increase the calories, and you may go to 110 calories per kilo per day or even higher. I know in nutrition rehabilitation centers in kids who had malnutrition and diarrhea, they would need up to 200 calories per kilo. So it can go very high. Now we're going to shift our discussion to complementary strategies during diarrhea. And we will start by talking a little bit about lactose intolerance. So as you know, an acute diarrhea will yield to damage of your gut, and therefore you're going to lose some of your lactase. And the lactase is typically anchored, the cells who are going to be damaged are at the surface, and those are high in lactase. When those disappear, the crypt cells who are under are immature and they don't have the lactase. So over time, you're going to observe a secondary lactase deficiency, and therefore, you're going to aggravate your diarrhea, cause malabsorption, and therefore have malnutrition. And we know that malnutrition aggravates diarrhea, as we have said before. In terms of the use of low lactose products in diarrhea, there is a little bit of controversy in the literature. However, there have been systematic reviews that have been done, and the WHO recommends first to continue breastfeeding during acute diarrhea, and for those who have persistent diarrhea and are not breastfeeding, you can consider low lactose products. A word on gut microbiota, and we will talk very briefly on substances such as pre and probiotics. At this point, ESPGHAN and other guidelines do not recommend the use of prebiotic in the management of children with acute diarrhea. And the reason is that there is not strong evidence and we need further research. Also, in terms of probiotic, the idea is that it probably could alleviate lactose intolerance and have beneficial effects on inflammation. As you know, recommendations on the use of probiotic is not consistent between guidelines. There is a great deal of research that's ongoing with respect to probiotic use in the prevention and in the treatment of diarrhea that's caused by infections. Of note, the Latin American expert group consensus recommends the use of some strains of probiotic for the prevention and the treatment of diarrhea. On one hand, some guidelines, such as the ESPGHAN, mention that active treatment with probiotics, in addition to RS, is acceptable, while multiple others, such as NASPGHAN, FDA, NIH, and others do not recommend the use of probiotic because there is not enough evidence on what's in the product and there is no regulation of the product. There's also NIH branches who report adverse effects with probiotic, and before we use it systematically, we definitely need a standardization and better safety approaches. So based on this, our recommendations are not to use probiotic in the treatment of acute diarrhea. There are other products that have been suggested in the management of diarrhea, such as MCTs or nucleotide, but benefits have not been clearly demonstrated in the literature and more research is needed. Vitamin A supplementation might be useful, and we know that it affects the immunity of a patient. Deficiency has been linked with risk of mortality due to acute diarrhea, and supplementation reduces the likelihood of diarrhea-related mortality. The WHO has done recommendations for supplements of vitamin A broadly in countries where there is vitamin A deficiency that has been noted. However, there are conflicts in terms of treatment with vitamin A in children who are less than 6 months and have GI disorders, acute diarrhea. And the supplementation of vitamin A recently hasn't shown an effect on mortality, so it's clear that there is controversy in the literature and we need more studies to be done for appropriate use. So now let's move on other practices in the management of diarrhea. It has been reported that in some instances, the management of diarrhea is not appropriate, and some highlights from a report in 2015 include the use of antibiotics and anti-motility drugs that should not have been used, food restriction, fluid restriction, and restriction of breastfeeding. So this is all concerning since those are all recommendations that are standing from the WHO. Not to restrict breastfeeding, not to restrict fluid, not to restrict food, and medication can be used in conditions such as dysentery, but we haven't approached that today. Another point that's important in the treatment and the management of the diarrhea is how do you communicate? And what most people use is an approach that has 4-prong: ask, praise, and advise, and check. And basically you want to know what are the medications that are given, what are the methods that should be used. You want to praise the patient if they are using the right methods already, and you will need to guide them in the use of ORS and zinc, for example. And the check is basically try to figure out, try to provide them with responses to their questions and maximize the chance of the child not to have diarrhea or nutritional problems associated with it. There has been an effort to try to prevent death due to diarrhea, and it's called GAPT. Basically what this effort suggests is to prevent diarrhea by acting on measles and on vaccination, especially for rotavirus, to protect the child by using right hygiene and sanitation, act on their nutrition, and improve actually education of parents. So this group, GAP, recommends in terms of treatment to have a better integrated community case management, use low osmolarity ORS, and also improve healthcare access to all levels. And this is not just the availability of ORS and zinc for the home, but also have an acute access nearby within 30 minutes to a hospital setting. Let's shift gear a little bit and talk about rotavirus vaccine in childhood. WHO actually recommends that rotavirus be included in national planning and national programs. And this effort should be complementary to efforts of providing access to ORS, zinc, and sanitation for children. Now, in terms of studies that were done by the GAP, they looked at, they provided a report to us in 2015 on preventable deaths from diarrhea. And this is a little bit grim at this time. We realize that there is still large mortality due to not only diarrhea, but also pneumonia. And none of the countries that are reported in this slide have been able to reach the 82% target for the diarrhea score that this group recommended. So it's clear that there is an urgent need to scale up the treatment measure for diarrhea and try to arrive to this goal. Now, I would like to summarize what we have learned today, really important facts. As you know, diarrhea is the second of the top 3 most common causes of death in children under 5. Nearly 50% of the deaths in children less than 5 are attributable to diarrhea, to undernutrition, sorry. There are 4 pathogens that are clearly linked to major diarrhea problem, which are rotavirus, cryptosporidium, Shigella, and toxin-producing E. coli. We talked about the nutrition implications of diarrhea that include anorexia or decreased dietary intake, malabsorption, increased requirement of nutrients, and metabolic inefficiencies. We really went over a lot of items around nutritional intervention since there is this cycle between nutrition and diarrhea. In the next slide, children with diarrhea should be assessed for dehydration so that you are able to decide what is the best treatment plan at home, in an outpatient setting, or an hospitalization with NG or IV treatment. ORS is the first treatment approach in acute diarrhea. Remember, breastfeeding is key. You should continue through the rehydration process. And what you want to do also is to continue feeding with high-calorie feeds, and you want to start that within the first 4 to 6 hours, depending on their age. Thank you very much for your attention and your participation in this lecture.